Good day, everyone. My lecture is entitled Keeping It Renal. I'll be lecturing on conservative kidney management. Here are my disclosures. At the end of the lecture, the viewers are expected to define conservative kidney management or CKM, to discuss principles, rationale, components, and benefits of CKM, to identify patients who should be offered CKM, to identify the right timing to offer CKM to patients. There's a good nationwide population based study, which is entitled The Impact of Dialysis Therapy on Older Patients with Advanced CKD. As compared to that of patients who are undergoing chronic dialysis, it seems that patients who are not undergoing dialysis, they have better outcomes regardless of gender, age, comorbidity index scoring, diabetes mellitus, chronic liver disease, cerebrovascular disease, dyslipidemia, coronary artery disease, and hypertension. In the same study, among patients who are 70 years old and above with a serum creatinine of more than 6 milligram per deciliter, majority of them were receiving chronic dialysis, while around 2,000 were not receiving chronic dialysis. And they found out that in terms of cumulative incidence of mortality, it seems that patients who are not receiving chronic dialysis have better outcomes in terms of mortality. They have lesser mortality as compared to that of patients who are receiving chronic dialysis. Another study which compares survival among older patients with advanced kidney disease managed conservatively versus that of patients who are undergoing dialysis. Among among patients who are more than 80 years old, there was no difference in survival between dialysis and CKM patients. In terms of quality of life with CKM versus that of dialysis patients, dialysis prolongs survival for elderly patients who have end-stage renal disease with significant comorbidity by approximately 2 years. However, patients who choose CKM can survive a substantial length of time, achieving similar numbers of hospital-free dialysis to patients who choose hemodialysis. Now, in terms of association of initiation of dialysis with hospital length of stay and intensity of care in older patients with kidney failure, it seems that compared to that of non dialysis care, patients who receive maintenance dialysis spent more time in the hospital and were more likely to be admitted to the intensive care unit. In terms of trajectories of illness among patients who are diagnosed with stage 5 CKD. Patients who choose CKM, symptoms from their comorbidities or kidney failure tend to remain stable until the last 2 months of life, at which time they can increase sharply, requiring careful reassessment and management. Now, if we compare patients on CKM versus that patients undergoing chronic dialysis, in terms of number of days spent in the hospital, it seems that patients who are on CKM have lesser days going spent in the hospital rather than patients who are on chronic dialysis. Now, let's talk about the components of CKM as listed here on the slide. In terms of medical management, the treatment that focuses on longevity is reasonable for patients with a favorable prognosis and preserve quality of life. Treatment includes medications for deceleration, progression of kidney disease, and medications for secondary complications of end-stage kidney disease. It's reasonable for patients who have unknown prognosis who desire to live as long as possible with the hope of achieving an acceptable quality of life. Now, in terms of medications for decelerating progression of kidney disease, now we all know that ACE inhibitors and ARB are effective in slowing the progression of renal failure in patients with advanced stages of both diabetic and non-diabetic CKD. Both drugs cause efferent vasodilatation, thus decreasing glomerular hypertension. Now, when you see progressive increase in serum creatinine, it suggests that there's presence of renovascular disease within the large or small arteries. If that happens, you may consider using non-dihydropyridines such as diltiazem and verapamil. Both drugs exhibit antiproteinuric and renoprotective effects if both drugs are not tolerated. However, for elderly patients, you have to take caution because it may cause severe bradycardia. And we all know that on target trial, it it showed that combining ACE inhibitors and ARB therapy should be avoided because it's associated with greater incidence of acute kidney injury and adverse cardiac events. Now, phenyrenone is a nonsteroidal selective mineralocortical receptor antagonist. It's more potent as an anti-inflammatory and antifibrotic effect than the steroidal mineralocortical receptor antagonist. It has shown to reduce the urinary albumin to creatinine ratio in CKD patients treated with an RAS blocker. It also resulted in lower risk of CKD progression and cardiovascular events than placebo. Its common side effect is hyperkalemia. Now, another new drug that is out in the market is sodium glucose cotransporter 2 inhibitors, otherwise known as the SGLT2 inhibitors. Its primary mode of action is to decrease glycated hemoglobin levels. Its secondary mode of action is natriuresis and glucose-induced osmotic diuresis, leading to a reduction in intraglomerular pressure. It has been shown by several studies that it has favorable renal and cardiovascular protection in patients with type 2 diabetes. Specifically in DAPA-CKD trial, CKD patients with or without diabetes, the risk of sustained decline in eGFR of at least 50%, patients are going to end-stage renal disease, or patients going into death from renal or cardiovascular causes were significantly lower with dapagliflozin as compared to that of placebo. Now let's go to medications for treating secondary complications of end-stage kidney disease. We have to manage adequately blood pressure control. We have to treat anemia, such as giving of erythropoietin stimulating agents with the goal of an hemoglobin between 10 to 11 grams per deciliter. We have to treat mineral bone disease through phosphate restricted diet and use of phosphate binders. We have to treat metabolic acidosis through giving of sodium bicarbonate. And we have to treat hyperkalemia through discontinuation of RAAS inhibitors, maintaining patients on low potassium diet. And if these do not work, then you may consider GI cation exchangers. Symptom management should occur concurrently with medical management of kidney disease or as the sole treatment approach. Most appropriate for patients who have a poor prognosis or whose prognosis is unknown and whose goals are for, for comfort purposes. Now, we have to do symptom evaluation. So we have to evaluate if the patient would have fatigue, pruritus, pain, dyspnea, nausea and vomiting, and psychological symptoms. It is important to elicit physical and emotional symptoms routinely at each clinic visits, and assessments can be completed by the patient with the help of a caregiver or support staff. Fatigue is the most common symptom among patients with advanced chronic kidney disease. You have to investigate contributing factors such as anemia, malnutrition, volume depletion, vitamin D deficiency, abnormal thyroid function, medications like benzodiazepines, anti-epileptics, antidepressants, or opioids. Now, you have to evaluate for sleep disturbances, depression, anxiety, and existential suffering. When it comes to pruritus, you have to investigate for reversible factors such as anemia, iron deficiency, cirrhosis, drug hypersensitivities, allergies, and contact dermatitis. You may initially treat with topical treatments such as emollients or topical steroids. For resistant symptoms, you may initiate with low-dose gabapentin at 100 milligram per day or pregabalin at, at the highest level of dose of 75 milligram per day. For pain management, you have to investigate for concurrent comorbidities such as diabetic neuropathy or peripheral vascular disease. You should also evaluate for a secondary complication of kidney disease such as calciphylaxis or bone pain from renal osteodystrophy. Untreated pain contribute to poor sleep, anxiety, and depression. For dyspnea, the possible causes may be anxiety, anemia, infection, presence of metabolic acidosis, and presence of pulmonary edema. If due to volume overload, then you should consider sodium and fluid restriction and giving of diuretics. Now, non-pharmacologic interventions you may do is sitting in an upright position, 45 degrees, airflow across the face, maintaining a humid environment, asking the patient to do pursed lip breathing, and giving a supplemental oxygenation. Low dose opioids and benzodiazepines can be helpful for dyspnea secondary to anxiety. All opioids should be used with caution since the active metabolites accumulate in kidney failure. Nausea and vomiting signify advancement of kidney disease. The common contributing factors to consider would be the presence of metabolic acidosis, medications such as opioids and antidepressants, and GI disturbances such as constipation or delayed gastric emptying. Non-pharmacologic management for nausea and vomiting would be asking the patient to eat smaller, more frequent meals, advising patient to eat slowly. You also may advise patient to avoid alcohol or foods that are greasy, spicy, or excessively sweet. You should minimize aromas like cooking odors, perfumes, and smoke. You should encourage patient to use loose in fitting clothing, and you ask the patient to maintain a relaxed upright position after meals to facilitate digestion. Now, for persistent nausea or vomiting, you may give ondansetron at 4 to 8 milligram every 8 hours as needed, haloperidol 0.5 milligram every 8 hours as needed, but the most practical would be giving of metoclopramide, which is a dopamine antagonist, which is effective for gastroparesis and uremia. But you have to watch out for extrapyramidal symptoms, which may also limit the use of metoclopramide. Now, kidney disease is a risk factor for depression and anxiety. Persistent psychological symptoms can worsen physical symptoms, negatively impact quality of life, and are associated with increased hospitalization. Sertraline, a selective serotonin reuptake inhibitor, is the first line agent for depression and anxiety in advanced CKD because there are no renal dose adjustment that would be needed if you're going to give sertraline at 50 milligram per day. Now let's go to advanced care or crisis planning. Advanced care planning is a process where patients, family members, and providers reflect upon the patient's goals and values to help inform current and future medical care plans, including end of life care. Many patients are asymptomatic at the time of CKM is elected. When symptoms appear, patients often fear and reconsider dialysis as a fix. Without adequate preparation, patients may view CKM as a temporary plan and may change over time depending on their current health state. Despite appropriate and adequate ACP and crisis management, patients may change their mind and request dialysis. It may reflect emotions such as worries and fears of end of life. Such concerns should be explored and patients' goals of care should be readdressed. For seriously ill patients who are near the end of life, this approach may also require skills to manage conflict and consideration of palliative care consultation. Patients with advanced CKD frequently have palliative care needs for years before death due to high symptom burden, functional decline, and poor quality of life. Patients who undergo palliative care consultation and hospice care are more likely to experience lower symptom burden at the end of life and to receive care consistent with preferences and are less likely to die in acute care settings or intensive interventions. Despite these potential benefits, palliative and hospice care are underutilized in patients with advanced CKD. Substantial barriers to palliative care include uneven access to specialty palliative care services, underdeveloped models of care for seriously ill patients with advanced CKD, misaligned policy incentives, and deficient training of clinicians in palliative care. End of life care is a symptom burden which appears to be relatively stable for patients being cared for conservatively until the last 2 months before death. In a prospective cohort study of conservatively managed patients, the last 2 months of life were characterized by an increase in fatigue, pruritus, drowsiness, dyspnea, agitation, and pain. Patients and caregivers experience high levels of psychological concerns, including personal and family anxiety, depressed mood, increased information needs, and practical concerns. End of life care is an interdisciplinary palliative care team may assist with difficult to treat symptoms or conflicting goals of care. Patients on CKM and their caregivers may also benefit from hospice services. Ideal candidates for CKM are as follows: patients who have life shortening comorbidities like end stage heart failure or end stage liver failure, patients who are frail with significant pre existing functional or cognitive impairment, patients who reside in long term care facilities, patients who have severe, continued, and irreversible physical or psychological symptoms, patients who view dialysis as prolonging one's suffering, and patients with irreversible mental incapacitation. Irreversible mental incapacitation are situations whereby patients have very little decision making capacity, patients who are unable to cooperate with the procedure of dialysis itself, patients who are unable to react to the environment or people, such as patients who would need restraints during dialysis, or they would require sedation during dialysis, and patients who are permanently unconscious, such as patients with on chronic vegetative state. When do we offer CKM? The discussion should occur at the time of dialysis options education, especially if EGFR is less than 20 to 30 ml per minute per 1.73 meters square. Patients experiencing a decline in clinical health or rapid kidney function loss may benefit from early discussions. And lastly, the conversation should involve the patient, family, or caregiver and essential members of the care team, including a nephrologist, nurse, and when appropriate, social worker and palliative care expert. This slide is taken from the conservative kidney professional pathway. This would help health professionals be guided on how to discuss chronic conservative management to their patients. So they have a plan, they have a management and support instructions for uh, healthcare professionals who would be discussing CKM. Now, the benefits of CKM are as follows. Patients avoid the potential setbacks accompanying dialysis. Patients are provided with a meaningful quality of life, especially for patients who are frail with advanced comorbidities. Patients spend their remaining survival not being hospitalized. Patients have a greater opportunity for symptom management and end of life care with palliative care and hospice services. And the hemodialysis hasten the loss of residual renal function. Maintaining residual kidney function can improve the patient's survival and quality of life. So, in summary, conservative kidney management is a treatment option for patients diagnosed with chronic kidney disease stage 5. The primary principle of CKM is to individualize patients' treatment to align with their preferences and personal goals. Published medical studies have shown that among elderly patients, there was no difference in survival between patients undergoing dialysis and patients who choose CKM. The components of CKM are medical management of patients' kidney disease, including symptom relief, advanced care planning, seeking palliative care services, and preparing for end of life care. Ideal candidates for CKM are patients with poor medical prognosis and patients with severe cognitive impairments. The best time to open the discussion of CKM is when the patient's eGFR falls between 20 to 30 ml per minute per 1.73 meters squared. And lastly, the ultimate benefit of CKM is patients are able to spend their remaining life meaningfully and not spend it on frequent hospitalization. I leave you with this quote coming from Hippocrates. We as physicians should cure sometimes, treat often, and comfort always. Thank you very much.